Hello everyone. I am Dr. Somalika Pal, Senior Consultant Neonatologist and Paediatrician at Cloudnine Hospital, Kailash Colony, New Delhi. Have you ever had concerns with your 1-year-old or 9-month-old not vocalizing enough or not talking enough? Do you have concerns that his language development could be delayed? Well, your baby could be suffering from a hearing deficit. It is extremely important to screen for hearing losses or hearing deficiencies right at birth. Congenital hearing losses are extremely common and amenable to screening programs. As per Government of India norms, all babies should undergo hearing screening, preferably right after birth or within the first month of life, to identify any hearing deficits. Certain risk factors are increasingly associated with hearing loss. If there's a family history of a hearing disorder, or there is some kind of an anomaly of the hearing apparatus, that is the external ear, there's a pit or a dimple before the ear, or there's a skin tag in front of the ear, which we commonly call pre-auricular tags. If you have concerns that your child does not listen to you or does not respond enough when you're calling out, or if your child has not been babbling or making noises or is not vocalizing enough with time, there's significant language or speech delay, that is a reason to go for hearing screenings. If your baby has been in the NICU and has required IV treatment or antibiotics for more than 5 days, or has suffered from any kind of infection in the intrauterine life, commonly viral infections like cytomegalovirus infection, or in the postnatal life with meningitis or maybe bacterial or viral in nature, then he or she is a candidate for hearing screening programs. So commonly, a common misconception is that if my baby startles to noise right after birth, why should I go for hearing screening? He most likely would be hearing well. But that has been shown to be unreliable in picking up a hearing disorder in up to 50% of cases. What happens is, most commonly when babies are startling, they may startle to any kind of stimulation, be it noise, be it sudden movement, and this sound may not be equal to the sound in the speech, in the range of hearing or threshold of hearing or the common speech threshold that we hear. Moreover, several other disorders can be progressive over time. So, we have to understand that 50% of hearing deficits are genetic in origin and most of these are single gene disorders. But having said that, up to 90% of babies who are actually identified by screening programs as having hearing disorders are probably not having a genetic etiology to their hearing deficits. So it underlies the importance of why each and every baby or a universal hearing screening should be recommended as per international norms or even American Academy of Pediatrics norms. It is important to identify the hearing losses early within the first month of life so that we can go for a confirmation of the hearing disorder, if any, by 3 months, 2 to 3 months of age, and start intervention or treatment as early as 3 months, latest by 6 months of age. Why it is important? Because if we miss this window of intervention or of detecting and diagnosing a hearing deficit, in such cases, the identification may get delayed, associated with a language developmental delay in the child, which can be as late as 1 to 1.5 years or maybe even 2 years when the caregivers pick up a significant problem in the baby. Hearing losses can be of the auditory type, that is the nerves that lead to the hearing sensation, that is a sensory neural hearing loss, or they could be of the conductive type, that is the pathway from where the sound waves are traveling inside the ear. There could be a blockage in the pathway. So many of these hearing losses are amenable to treatment or evaluation. The causes could be infectious in origin, which again, if identified and picked up early, we can use certain modalities to help your child. So early intervention programs would actually help the child hear better, sustain in a noise-rich environment or a sound-rich or a word-rich environment, and the child's language and developmental delay or speech issues can be addressed much better. So it's extremely important that when you're choosing or picking a center for delivery of your baby, or when your baby is born, you should ask for and seek for hearing screening in your baby, and thereafter continue to observe and watch for any concern that he or she may have in terms of responding to a sound or a command, verbal command, or in terms of language. Significant notable external deficits like a white forelock or some neurodegenerative disorders, neural diseases may also be a high risk factor for hearing, in which cases your screening pediatrician would be alerting you to hearing screening. Commonly, two kinds of tests are available for screening for hearing disorders in children. One is an otoacoustic emission and the other is an AABR, that is an automated brainstem audiometry. So either of these tests for screening, commonly for well babies who have not had a history of NICU stay, who are not born preterm, or who do not have a significant risk factor like a family history of genetic disease or suspected single gene disorders or any kind of external ear anomalies, would be screened by an OAE, and the others would require an AABR. In case your baby fails in an OAE evaluation, the subsequent testing could be done by an ABR. If at all these screening tests pick up a hearing deficit, then your baby would end up requiring a detailed diagnostic evaluation for hearing disorders, and subsequently early intervention programs or corrective steps, as in how whatever is indicated based on whether the hearing deficit is of sensorineural or conductive in origin. That is all. Thank you.